Bismillahirrahmanirrahim. Welcome to the second part of very important topic we are talking about, that is congenital hearing impaired child. In the part 1 we discussed different etiological factors which can cause hearing loss in a newborn baby, and the link for that part is there in the description, so you can check it out. So today we will talk about different milestones in the development of the speech, and then different tools to diagnose the hearing loss as early as possible. So before proceeding on, please like and subscribe the channel. This is the nutshell of or summary of milestones in speech development. And as we talked about last time, that speech is the output while input is hearing. So by the development of the speech, indirectly hearing is also being assessed. At 3 months of age, the baby should be able to have 3-letter words. That's what we call as coo. At 6 months, baby starts babbling. At 9 months, he starts imitating the speech. At 1 year of age, he can speak 1 or 2 words. At 18 months, vocabulary increases up to 18 words. At 2 years, he can use 2 words phrases. At 3 years, 3-word phrases. And 4 years, 4 or more sentences he can use. So a bit detail of that, very quickly I will go through that. Cooing sounds like O, E, A. A baby will be doing this at 3 months of age. He will smile at people. He will recognize your voice, especially of the parents. Then his cry changes for different needs, like laughs and giggles versus cries and fusses. Then at 6 months of age, 6-letter words like babbling, he will babbles and repeat the sounds. Giggles and laughs more, of course. Uses his own voice to express pleasures and displeasures. Notices and recognizes the different sounds. At 9 months, imitates the speech sounds. Imitates non-speech sounds. Imitates actions and gestures. Looks at objects when someone is talking about them. Recognizes their own names. And babbles longer strings of sounds. At 1 year of age, his vocabulary increases. He starts meaningful use of the words like mama, papa, begins to understand the words, requests, instructions, especially when these are accompanied by gestures. For example, when you ask him to say bye-bye, he moves his hand. He answers simple questions non-verbally with body language and imitates different patterns of speech. Recognizes the words for common items like ball, shoe, cup, dog, cat, etc. At 1.5 years of age, vocabulary is now up to 10 to 20 words. Repeats the words overheard in conversation. Recognizes and points towards the familiar objects. Knows different body parts now. Follows simple commands like put the tie down, roll the ball, etc. And understands simple questions like where is your cup, where is your toy. He is able to say 8 to 10 words by the age of 1.5 years. 10 to 15 words by the age of 2 years. He puts two words together. For example, he will ask more cookies. He points to 12 familiar objects when these are named. Follows the direction. And you ask, give it to mommy. 3 body parts on the doll or on himself or another person. Names 5 family members. Produces different animal sounds. At 3 years, 3 word phrases. Then he uses no or not in his speech. Vocabulary is more than 200 words. He understands and responds to where, who, what questions. Carries out a series of 2 simple commands. He uses the plurals now. At 4 years, 4 or more words or sentences. Uses ideas, feelings. Talks about activities at school, daycare center, or at home. In chronological order. Identify different colors, group objects. And 5 years, he carries out series of 3 directions. Demonstrate and understands the passive sentences. Use compound and complex sentences like can't, don't, won't. He defines the words. He can tell you different rhymes, points to some, many, several, tells the address or even telephone numbers. So this is the nutshell of these milestones. Very quickly, at 3 months, cooing and gurgling sounds. At 6 months, babbling sounds. 12 months, first word he will be able to speak, usually mama, papa. At 18 months, 5 to 40 words he knows. At 2 years, 150 to 300 words. At 3 years, 900 to 1000 words. And 4 years, 2000 words with 5 plus word sentences. And at 5 years of age, he identifies the letters, creates longer sentences. So, if someone is lacking behind these milestones, first suspicion should be that his hearing may not be normal. And there are a variety of approaches for hearing assessment in such children. And this choice of test, of course, will depend upon child's age, his intelligence, and his motor abilities, so that no other abnormality should be there. Best results, of course, in multidisciplinary pediatric assessment centers, where environment and organizations are geared up, thorough history and clinical examination. Then there are screening tests. Regularly, these are being done in European countries. Hearing is important, so diagnose moderate and severe hearing loss, we can go for regular screening tests, and these tests can be done at the age of 7 months, 2 to 4 years, and shortly after school entry. And any child who persistently fails these screening tests, he should be referred to higher center for a full assessment of hearing. Then screening tests can be done at parental concern, or if the baby was having meningitis, or there is family history of hearing impairment. So most health authorities, they maintain at high risk register of families in whom possible prenatal and perinatal causes exist. The screening tests which are available at 7 months of age, there are distraction tests. At 2 to 4 years, we can do these distraction tests along with some conditioned response audiometry, and 5 years and above, we can go for pure tone audiometry. So subjective hearing tests, they include behavior techniques up to 6 months of age, distraction techniques from 6 months to 18 months, visual reinforcement audiometry from 9 months to 3 years, conditioned reflex audiometry, which is also called as performance testing, that is 2 to 5 years of age. Speech discrimination test also can be done from 2 to 5 years of age, and 5 years and above we can go for audiometry. So what are these behavior techniques? This is for newborn babies up to 6 months of age, based on presentation of loud sound and observation of baby's response. Usually the response to a loud sound is startle, blinking, crying, or cessation of the activity. A positive response is one in which there is significant alteration in the activity. For that, we do what we call as MORO reflex. It is also called as STARTLE reflex. This is in response to the sound, the baby throws back his or her head, extends out the arms, cries, and then pulls the arms and legs back in. Even a baby's own cry can startle and begin this reflex. This reflex lasts about 5 to 6 months of age. Then distraction technique. This is for the age group of 6 months to 18 months. Here the child is comfortably sitting in his father's or mother's lap. Tester distracts the child by making the sound of various intensities, while his assistant is catching the attention of the baby by doing some activity in front of him. So this is the tester which will make different noises, first on this side and then on the other side of the baby. A positive response is when the child turns to the sound. So this procedure is repeated on both sides, and this test includes conversational sound or conversational voice for low frequency, and for high frequency rattle is used in younger children. For the age group of 9 months to 36 months, we do what we call as visual reinforcement audiometry. This is uncommon in UK, but it is more common in USA and Australia. It is, you can say, a free field audiogram also. Child sits in an acoustic room, soundproof room, at a table, with a parent is allowed to play with some toys, and these are two speakers on either side. Here also these are the two speakers on either side. So a sound is being played by one of these speakers. If child turns to a correct procedure, a visual reinforcement stimulus is presented adjacent to the speaker, for example flashing a light to enforce the turning response. Testers or examiners, they sit outside the room and they observe the procedure through a one-way mirror, so the child cannot see those examiners. Conditioned reflex audiometry, it is also called as performance test. It is at the age of 2 years to 5 years. In this, the child is asked to perform a specific task. For example, putting a marble in a cup, or is asked to give the toy to his mother. Stimulus may be a spoken word, or it may be a tone produced by a handheld audiometer, but it is important to avoid any visual clues and cues. Then is speech discrimination test. This is again for age group of 2 to 5 years, and these tests involve asking the child to point to or handle a variety of toys. These toys are selected to cover a range of speech patterns, and it is called as McCormick toy discrimination test. In this, there are 7 pair of toys with the names which are acoustically very similar. For example, tree and key, shoe spoon, cow house, duck cup, man lamp. This McCormick toy discrimination test, it uses these 14 paired words, 7 pairs. These are generally recognized by the children from an early age, and each word in the list, it has a matching item in the set and a paired item with a similar vowel or diphthong but different consonants. For example, here the vowel in the duck, it is U. In the cup is also U, but consonants are different. Here the vowel is O in shoe. In spoon also O, but consonants are different. So only those toys that are recognized by the child, they are used, and aim is to establish the speech level that gives an 80% correct response rate. Pure tone audiogram, it is a subjective test and it is 5 years and above. This is a pure tone audiometer, and this is how the child responses, and this is what we get as a result is pure tone audiograms. So pure tone audiometry is the procedure, pure tone audiometer is the instrument used, procedure is pure tone audiometry, and the result is pure tone audiogram. On pure tone audiogram, we have got 4 possibilities. Either it is normal, or it shows a conductive type of hearing loss, or it shows a sensory neural hearing loss, or it may show us a mixed type of hearing loss. So most of the children at 5 years of age, with a little encouragement, can be persuaded to perform an audiogram, if only at 3 frequencies in each ear. So all these were subjective tests. Then we have got objective hearing tests, in which we don't need the response of the patient. So there we have got, in early age, we have got auditory response CRADLE. Then in first year, we can go for otoacoustic emissions. And then last but not the least is what we call as evoked response audiometry. It is also BIRA, that is brainstem evoked response audiometry. Auditory response CRADLE is for the newborn babies up to 6 months of age. They are there in the cradle with the monitor, and there is this cradle has got different knobs. The stimulus is 5-second burst of 85 decibel sound pressure level. It is made in the earphones attached to the ears of the baby, and then a microprocessor analyzes the response of the sound stimuli, taking account of baby's overall level of arousal, and makes an objective verdict of the pass or fail. This device monitors basically 4 responses. One is head turning, then is startle response, then body movements are recorded by the pressure transducers in the headrest and the mattress of the cradle, and then respiratory changes are monitored by a transducer on a band around the baby's chest. Much of the recent work is with otoacoustic emissions, which is for the age group of 0 to 1 years of age, and it is used as a screening test for sensory neural hearing loss. Low intensity sounds are produced by the outer hair cells of a normal cochlea, and these are elicited by the microphone placed in the external auditory canal, and sound is in the reverse directions, travels from the outer hair cells, that is from the outer hair cells to the basilar membrane, from there to the perilymph to the oval window, from there to the ossicles and then the tympanic membrane, and then the external auditory canal. So this is in the reverse direction. There are four types of these otoacoustic emissions. One is spontaneous otoacoustic emission, means that it is without any sound stimulus, and it is up to, if the hearing loss is up to 30 decibel. Then is the transient evoked otoacoustic emissions. These are emitted in response to stimulus of a short duration sound, which may be a click or the tone burst. Then there is distortion product otoacoustic emissions, in which the sound is emitted in response to stimulus by simultaneous tones of two different frequencies. And then there is sustained frequency otoacoustic emissions. This is in response to continuous tone, but this is not used clinically. So these are used for screening and to differentiate the cochlear from the retrocochlear hearing loss. Then is the cortical evoked response audiometry. It is indicated if there is any difficulty or uncertainty in the results of conventional distraction techniques, or if the child is too young for conventional testing and there are doubts to child's hearing ability. Usually a modified cortical response audiometry we use, that is what it is called as BERA, that is brainstem evoked response audiometry. This is generated by the auditory nerve, and information regarding the origin of individual wave components of the BERA, it was provided by Moeller and Janita, and for that we must know the auditory pathway, that is from the cochlear nerve to the cochlear nucleus to superior olivary complex, from there lateral lemniscus, then is the medial geniculate body, and from there it goes to the auditory cortex. So whenever a sound stimulus is being produced, you know that action potential is generated and the nerve impulse travels from the cochlear nerve throughout this, and if we can record it, we can know that the sound is traveling on a normal pathway or there is some hindrance. So different electrodes are being placed over the vertex to record these different waves. I will not go into the technical details of these electrodes, but wave 1 you must know. This is the BERA, how it will be presenting. So wave 1 is the representation from the compound action potential in the distal portion of the cranial nerve number 8, that is the vestibulocochlear nerve. The response is believed to originate from efferent activity of the cranial nerve number 8 as they leave the cochlea and enter the internal auditory canal. Wave 2, it is generated by the proximal 8th nerve as it enters the brain stem. Wave 3 is when the cochlear nucleus, that is the second order neuron. Wave 4 is when the sound has gone up to superior olivary nucleus. And wave 5 is, generation of wave 5 reflects the activity of multiple anatomic auditory structures. Sharp positive peak of wave 5, it arises mainly from the lateral lemniscus, and following the slow negative wave represents dendritic potential in the inferior colliculus. So wave 5 is the component analyzed most often in the clinical application of the BERA. Wave 6 and 7 waves, they appear to be generated in the inferior colliculus, perhaps in the medial geniculate body, and then go up to the auditory cortex, but it takes much of the time. So in the test usually we go from wave 1 to wave 5, and this is a normal waveform for BERA. You see here at 0 the sound stimulus is given, and somewhere after the sound stimulus 1.5 milliseconds that the wave 1 appeared. So from 0 to 1.5, this is the time taken by the sound wave from the external ear to the middle ear and then to the inner ear fluids and to the cochlear nerve, because wave 1 is that it is when the sound stimulus has arrived at the cochlear nerve. Then wave 2, wave 3, wave 4, wave 5 and wave 6. Not only this latency, then the peak of these waves and interwave time period is also noted. For example, from wave 1 to wave 3, the normal duration is 2 milliseconds. So it is somewhere at 1.5 millisecond and wave 3 is somewhere at 3.5 millisecond. So the time taken by the nerve impulse to travel from wave 1 to wave 5 is around 2 milliseconds. So if it is increased, so it means there is some problem here in between. And from wave 1 to wave 5, after the appearance of wave 1, almost 4 milliseconds are being taken and wave 5 appears. But if it takes longer time, so it means that there is a problem in that auditory pathway. So this is how we can know that the disease is causing a problem at which site and whether it is a cochlear problem or it is a retrocochlear problem. So with that we come to end of this session. In next session we will discuss how we can help such children in which we would have diagnosed this hearing loss, and what tools are available to help these children to hear and then to develop a speech. You are requested to subscribe the channel, and thank you very much for watching.